Time now for this week's Health Matters. Paul Critz with you, and physician assistant Lynn Szabo. And this week's topic, something that has been all over the media and is sort of the thing that's making us all look into the future. This is the first thing I've seen in a long time that I could look at right now and go, "Yep, this is going to change everything." So many times, these sorts of that just kind of happen to you. But this is like AI. AI is going to change everything.
Right. Artificial intelligence in medicine.
How's it going to affect your job?
I think it already is affecting my job, and I'm probably largely unaware of it, actually.
Okay.
So, so what is it? So it's a computer system that's able to perform tasks that normally require human intelligence. An oxymoron, if I've ever heard one. So, and as it relates to medicine, the goal is that it brings the knowledge of all medical knowledge to the use of the underserved. That's like it in its purest form. Mm-hmm. But that's not really how it's being used. At least that's the goal that the providers are looking at. Okay. But it's also used in medicine for things like billing, what an insurance company will cover, and, for example, how to staff.
Wow. Okay.
Which is kind of important, except when it's not,
Well, yeah. And I want to get into how something like that breaks down.
Right.
I can understand staffing is just a matter of arranging things in a logical sort of scenario,
right.
But logic doesn't always dictate what happens.
So like today being Easter Sunday, probably not much going on in the ER you would expect, and historically not much except for the tsunami, except when there wasn't.
Oh, right, yeah.
So anyway, so it can be helpful with things like reading CT scans, and x-rays and stuff, and applying diagnostic algorithms, which is super helpful, but not really, that's like perhaps the science of medicine, not so much the art. And it's being sold to providers right now as helpful with documentation, because that's the bane of our existence, is charting.
How does it help with documentation?
Well, at the end of the day, if you want to stay on time and if you want to keep people moving through, which is what administrators are hoping we do, then you don't chart until the end of the day. Mm-hmm. And it can take hours to chart. I used to chart on when I was in Humboldt County, and I'd be there until 9 or 10 at night.
So I've seen at the end of ER, at the end of the day, somebody sitting there, and typically I think back in the days in the 90s, they'd have a little recorder that they recorded something and they're updating.
I love dictating.
Is that charting? What is charting?
That's charting, but that's like ancient charting. So that's not something they do anymore. But it was super fun. So what you do is you're writing notes on the medical encounter, and documentation drives billing, right? And so they want not only as much information in a note, even if it's like a 2-minute cleaning out your ears note, because they want billing points for that. And also, since the Affordable Care Act, they want it also to include things like healthcare maintenance. And so you have to, it's involved to write a note even for a simple visit, is kind of the bottom line. And to get everything in a way the billers can interpret all the billing points is super important. And it takes forever, especially with a computer that doesn't necessarily always cooperate.
So I want to understand, because again, I still don't know what charting is after you told me this.
Okay.
It's basically, so you've taken notes, basically writing down or typing out or whatever. You've taken notes through the course of a day on a number of patients. At the end of the day, those notes have to be entered into their permanent record. Is that what charting is?
So it's charting in my brain. I seldom write anything down, maybe a total of 7 words at the most. And then it's in my brain. And remember, everything that's positive is noted. Everything that's negative is just negative, right? And so I write a subjective, so what the patient says, and vital signs go into objective, which is the next topic, and physical exams in the objective part, and then assessment and what I think of that, bringing it all together, and then plan what I'm going to do about that.
Okay.
Does that make more sense?
No.
Okay.
Where you're talking about these things that you're plugging in and on, is that the chart? See, I don't even. You've jumped right into this nomenclature, and
right.
I get it. It's basic data entry is what you're doing essentially, right? Yeah. But is there like there's obviously a form that
there's a template. It's electronic template within the chart, and some people write their templates ahead of time because some visits like routine diabetes check or something like that is pretty straightforward, and sometimes you just kind of winging it because what the patient says they're there for is not really what they're there for. And then there's like whole ancillary things that you have to add on, like healthcare maintenance and things like that. That's like cholesterol.
Sure. So, I get it now. And that's all stuff that back in the 90s when I'm watching like ER and things, that's stuff that was done by hand at the end of the day. Right. And now it's you're entering into who provides you were talking about that template. Who provides that? The template of the things that you have to enter.
It's the computer program that the organization you work for has purchased.
Okay. So
there's different ones. The most common one up here is Epic, which is most common nationwide.
Okay.
And Epic is for big systems. For example, Sutter is connected. Sutter has Epic. Open Door has Epic. You can drop into a Sutter ER visit and get information out of there. Things like that. The Sutter Community Clinic has Epic. UHS has NextGen, and that's kind of a problem because those two systems don't talk to each other.
Okay. Is it also a problem that you would have like are you able to enter it? Does the template provide an opportunity for you to enter in all the salient facts, or does it try to steer you into specific things, or is it kind of I'm curious as to...
It depends on the template. So I speak like 7 electronic health records, and some really try and steer you into stuff, and some are like more freeform.
Yeah. I'm wondering about that because that would influence everything.
Right. That would be AI.
Yeah.
Right.
Yeah. Okay. All right.
So when I fill, let's say I write a prescription, and some templates will tell me, how much when you write for an inhaler, you have to record it in grams. You think you could just write one inhaler, but it has to be 17 grams. And so some inhalers are different grams, and so the template will suggest. So that's AI.
Yeah.
That's useful AI.
That is useful AI, yeah.
And then it underlines if you spell something wrong. That's useful AI. But the other thing it does is it tries to anticipate, like when you're texting.
Yeah, I know what you mean.
It tries to anticipate what you're going to say, and oftentimes, that's the same kind of frustration.
Right.
Because you're not always going in the right direction.
I don't mean to undercut the narrative flow of this, but are we working toward a situation in which AI then will offer, if it doesn't already, like another, like here's a diagnosis?
Yes, we are totally working toward that.
And that isn't the case yet.
Well, to diagnose, there's algorithms.
Right. Okay.
And so if this, then this, if this, then this, if this, then look at this, and if that, then this. So sometimes it's super straightforward. So sore throat, positive strep test, must be strep, give them, medication. And sometimes it's really complicated, like, maybe with an endocrine disorder or a neurologic disorder or even cardiac stuff. And so what AI does is applies that algorithm that the provider is either looking up or has in their head, and comes to the conclusion, like, what is the diagnosis? So AI, I guess you could say diagnosis, but it's not always right.
Right.
So that's the problem, the misdiagnosis.
Sure.
So the best diagnosticians only get stuff right about 40% of the time.
Really?
So human being doctor, super smart, super educated, super resourced, okay? Probably doesn't work, super resourced is not really in Del Norte.
I heard
super
you,
smart,
I heard you
super
put the brakes on
educated,
that
totally
sentence.
in Del Norte, but super resourced, not in Del Norte.
Okay.
So oftentimes it gets about 40% diagnosis correct. But that in the art of medicine is selecting the most likely working diagnosis. This is what science is. Remember we learned this in COVID? So pick your best hypothesis start working that and change it
and see
as
how
you
it
get
holds
more
up.
information.
Yeah.
And some of that information comes with time. Okay.
And comes with your diagnosis and the treatment that ensues failing
Right.
because it was a misdiagnosis. And then
Right.
you're okay.
And you can learn a lot from misdiagnoses.
Yeah.
And so sometimes when, let's say you have an illness, you go to the ER and you're misdiagnosed, maybe. And then, another provider misdiagnoses you. Then the next provider who gets it right actually is not necessarily smarter, but has just benefited from history. Does that make sense?
Yeah, it does. It
Yeah.
does. And again, not to undercut, because I haven't read ahead.
Okay.
But AI would do the same thing.
AI has the same process.
But a lot faster.
Right.
Wow. Okay. Okay.
But it also is, data in is only as good as, or data out is only as good as data in, right?
I think with AI, though, that data in is a much bigger set or subset
It's
because
huge.
it's historical and it's
huge,
based upon, yeah.
and it reflects things like cultural bias.
True.
So let's say you're the super doctor that brain is being hooked up to the computer for simplicity. So how do you know that AI isn't absorbing cultural bias? So just because you say the patient is a 24-year-old African-American woman, and then you write the whole thing out, give the whole history, put the data in, and then you change it saying it's 24-year-old Caucasian female, and then do you get to different data points?
Wow. Okay.
You kind of, depending on the problem, maybe you should get to different data points.
Yeah.
But that data point should be scientifically accurate and not a minimization of care. So if that provider is less likely to believe people of color need, are telling him the truth and need higher levels of care, then that's going to be reflected in the AI.
Interesting.
In
Sure.
the algorithm.
Sure.
So, and that person where that information is coming from, that, super doctor brain, might not even be aware of it.
But then downstream, though, isn't that something that very easily could be addressed by changing the algorithm?
I think it's actually amplified.
But it would.
Yeah.
Oh, I don't see it that way. But I don't know. I don't. It's
I think it could be amplified.
if you were to come up with like an algorithm being used by AI that if we became conscious of it, being based upon bad data, because that AI then is all a single source now, you could program for that bias.
Do you think it's going to always be? I don't think it's going to be a single source.
I think it will be a single source. That's
Like
how AI
eventually,
would have to
maybe.
work.
Eventually.
If it's not well, then each discrete single AI node,
Right.
because that's the whole idea behind AI. It can't be in a vacuum by
Right.
itself. It's not going to learn anything. It
Right.
has to be tied in with all these
Right.
other sources. So
I think it's going to be super subtle and not that obvious.
okay.
And I think some people will be hurt in the process of learning it.
Maybe so, but I think it'll be a lot easier and more straightforward to address than approaching millions of discrete human doctors and trying to
Right.
factor out bias. then.
Maybe it depends where you are and what your situation. So it's also dependent on data gathering. So it's always a step behind. And so this is like COVID.
Right.
So what if we used AI to fight the next COVID-like epidemic? Okay. It's
Could it have been worse?
I know. That's true. But
I'm
some
not sure.
places did better and
Right,
some
right.
places did worse. So it depends what model you use. But, I don't know that it's going to be adaptable enough to the news coming in the same way that like an individual brain is. It's hard to say.
Again, I need to argue. I find myself on the side of AI in a lot of this because I have seen, and we've just been talking about with bias, and then now with handling the pandemic, something a little sluggish and not reacting to every frickin' headline every day might have been a good thing during the pandemic.
Is that how doctors reacted to it?
I think now looking back, when we look at what came out from the
think we all
CDC regularly, everybody was just this, no this, no this, because
Super
everybody's
reactive. So
trying
it would
to
take
do the best.
reactivity out of it.
Maybe if there's just a beat factored into it where data is aggregated and then processed through the algorithm, that may actually be a good thing and keep the hysterical monkeys, from making all the noise and jumping up and down.
Possibly true. You also have to have a good data source, I would argue.
Yeah.
Because, like maybe China wasn't.
How so? You mean just because it wasn't unfiltered data? It was perhaps curated
because
to some degree?
political motivations change data to fit the hypothesis instead of the hypothesis fitting the data.
Yeah.
So it's also not supposed to replace the provider, although there is a giddy whiff of that in what I read.
Oh, that'll happen here.
I know.
That's what in rural communities, especially with no resources and not a lot of health care and not able to attract doctors. And right now, the first step was, I'm going to go see my psychiatrist on a Zoom call. That's the first step. And the next step is, okay, you're going
to be talking to Hal.
You'll dial up,
telling him your dreams and stuff, analysis.
Singing songs with him.
Yeah, I think there is a whiff that it's going to replace providers. I think that's actually a hope. But also, there's just, what if the provider disagrees with the outcome that the AI has proposed? Mm-hmm. How do you argue with the machine?
Well, it seems like the first thing you set up is who's in charge here.
Right. So who's setting it up to decide who's in charge there if providers are going to disappear?
Yeah.
I don't know. I think there's a lot of financial motivations in the wrong direction anyway.
Well, yeah, almost always. That's
and how do you argue with it? Because essentially it's kind of a black box.
Mm-hmm.
You know?
Well, yeah, but isn't a doctor?
No, I don't think so.
Why not?
You can argue. You guys argue with us all the time.
Yeah,
I'm not a doctor.
And what's the outcome? What's the outcome from that? And come on, quit saying that. You're a doctor. Come on.
He's trying to get me arrested. No, I'm not a doctor.
Come on, say it into the microphone, Lynn.
I am not a doctor. So
it just seems like, so doctors have this incredibly esoteric knowledge that ordinary lay person doesn't have access, or does have access now, but can't understand it.
Right.
That's a black box to me. If what a doctor is saying is just coming out, okay, well, all I have is your word for it, and I can't argue it in any sort of way. I can't argue with it in any sort of way other than to just go, no, I'm not going to do what you tell me to do.
Don't you ever ask questions in the exam room? Or
sure, I ask questions, but
shut down.
Is that the same as arguing or being confrontational about, or maybe that's not what you meant initially, but asking questions doesn't seem like that's a...
Oh, people ask questions all the time.
Yeah.
And I think any good provider would be answering them.
I think the one thing that AI has demonstrated it can do, and you can go online right now and do this all day long, is it can answer questions.
That's true, like a chatbot.
Mm-hmm.
Yeah.
Mm-hmm.
That's true, but you just before we got on the air, you interfaced with, I think, an AI.
That's a different sort of thing.
Why?
Because it's over the phone and it's mass and it's open to anybody. This would be like I know it's the same thing with the other, but this would be more specific, and they'd be looking more specific in your stuff. And yes, I would probably end up yelling at it too, because I can't stand that stuff.
Right.
I would much rather talk to a human being.
Right.
But I'm old-fashioned.
I know. Me too. So
some might say.
And I'm wondering if AI really knows patients. So patients in Humboldt County are different than patients here. There's kind of different worldview. There's different what they're trying to get out of healthcare, and it's not necessarily bad or good. It's just different. And so, could AI pick up if somebody was talking in Del Norte? So, a Del Norte patient, things like, I fell to the ground, I passed out, doesn't necessarily mean the same thing here that it means maybe in other communities, or say in a medical school, in a teaching situation. So if somebody just said this to me the other day, that she was coming in to be seen because she was passing out. And so, that put the medical assistants into a Twitter because they didn't know what to do with her. But if you asked her, did you actually fall to the ground? Did you actually lose consciousness? No, she didn't.
Okay.
She just felt dizzy.
Okay, yeah.
And that was the bottom line. So patients say stuff that means different things. And so if that was plugged into an AI, that person passed out, the visit would have gone in a completely different direction. Right. But I've been around long enough. I know this patient. I have an ongoing relationship with this patient. And I knew to say, wait a minute, can we look at that a little closer? What do you really mean by that? What do you really mean by that? So I think a lot of providers, try and actually understand what somebody's saying. What she's saying is that she's had an event that scared her.
Yeah.
And that she's upping
she felt like she was going to pass out.
Upping the severity of the event so she could get attention for it.
Yeah.
I mean, not in a bad way, medical
or not even in a
appropriate.
conscious way, too.
Yeah.
It could have just been, she just was like, that's how.
So part of it was she was scared. Okay, so a human being could understand that. Would a computer get it?
I got it all. I see the future.
You see it?
I do.
Okay.
Okay, so what'll happen is you'll have this, you'll have your AI, your doctor robot, whatever. But you'll have a human face. You'll have an interpreter. You'll have like a greeter at Walmart. You'll have somebody there asking you the questions and entering it in. You'll have like somebody to interact with. It'll be a real person, but that person won't have to have a medical degree and can be paid minimum wage. They just need to be able to talk to you and to get you to
Are you picking up on my horrified look on my face?
That's where, that's how this will shake out. I predict.
I think so too, actually.
God, it's horrifying.
It's kind of like ordering a hamburger at Burger King.
Yeah, they're going to press
And how easy is that?
Oh my God, right?
So anyway, will it be usable? That's my next thought. And what do you do during power outages? Well, you just get a generator, I suppose. But power outages, the whole electronic medical record system goes into chaos.
Oh, right.
Tumbles into complete chaos. Is this going to like follow that?
Wow.
So I think of AI as a large, shallow data pool, but the provider has the deeper knowledge of the individual. Agreed? I mean, do you see that?
Say that again.
The AI is a large, shallow data pool, but the provider has the deeper knowledge of the individual.
Sure.
So, and then an individual and also the community. So how do we know that it's doing it right? Because there's no transparency. I think we kind of touched on that already, though.
I'm sorry. I'm having all this dystopian stuff come through.
Oh, my God.
In my mind. I'm imagining a future in which we all have our own AI avatars that carry all of the information and interact with us.
God, I hope I'm dead by then.
That will interact with us and carry all of our information, and then it will be our gateway into the AI world, and it will take our information and us and our avatar and everything, and it will have interacted with us minutely throughout the course of our lives, and we'll be able to then communicate that to the AI
life
that
becomes
doesn't.
Video game?
Not necessarily. No, not necessarily. No.
So if you disagree with your diagnosis, do you like whip out your sword and start?
Well, if you disagree, I don't know. I'm not sure about that either. How that'll shake out. That also means what state will capitalism be in at that point, and how coercive will it become, and if it's even still a thing. There's all sorts of questions about that. But yeah. Who'll be in charge? You or your avatar? That's a good question.
Kind of sound funner on some level.
How so?
Because it makes it a game, I guess.
It's yeah, I suppose.
Yeah.
But when we're finally get into quantum encryption and having all of your personal data tied up in an avatar that can't be like hacked because it's using, I don't know, bosons. It's just.
But I think there's a sadness about the providers not meeting around a table at the end of the day and being able to talk about the finer points.
Well, that's as long as there are providers that have a nostalgic outlook on that situation. Once you're all gone,
the computer.
Be
nostalgic. There's an art to medicine.
Huh?
There's
an art to everything.
The art to medicine.
Sure.
Yeah, I don't think it's nostalgic, although that's kind of an interesting point.
Oh, it will be. It will be when there's fewer and fewer of you to look back on those grand. I mean, yeah, I remember. I have an analogous sort of situation with the editorial meetings in magazines and newspapers that I've worked with, and those don't happen anymore either. So it's like, yeah, okay, it changes, man.
Yeah.
Everything changes.
I guess you're right, but
I can't. It's so if we're having a hard time getting doctors and getting health care to places like rural America, how is AI then going to not be a good thing, kind of, all things being equal?
Here's how.
Okay.
So what if somebody like loses the vision in their eye all of a sudden, and they end up going to the ER and they get evaluated, and there's, they don't have a stroke, but they actually have an eye problem. So AI recommends, let's say, ophthalmology evaluation. It doesn't know that we don't have an ophthalmologist. So then you're saying there's going to be an AI ophthalmologist. Okay, so even if we do that, how does somebody get a physical exam out of an AI ophthalmologist, because that's really what they need is somebody to look at their eye. So I don't think it's going to be. I don't think it. I think the promise is limited, and not necessarily everything a rural community will need.
I think you're trying to make the AI be everything all at once, and I think that's perhaps a fallacious way to proceed.
Okay.
It's more, in my mind, more likely that somebody loses vision in his or her eye, goes to the ER. The AI initially is going to be the doctor at the ER. Right. And it will give him, just like what happened to, this is all ripped from real events, what Lynn is referencing. If somebody comes out of the ER, then they'll come out with that diagnosis. And in that regard, in that atomic little existential node that happened to them in the ER, doesn't matter whether a human or AI gave them that diagnosis.
Except there was no exam.
Who says there was no exam?
How does AI do an
exam? I don't. That's a question that somebody who's going to go.
That's a computer programmer.
No, not necessarily a computer program. But if you're going to have AI in something, you're going to have be able to input physical examination fact into it some way. Right. I don't know. That's something. Whoever, when they come up with the AI ER doc, there's going to have to be somebody entering in the actual. In the future, you'll probably put your head in something, and they'll go, "Oh, here you go." And we've just seen it, and that's whatever future tool there is out there, scanning tool. But AI isn't going to do. AI is just going to take the information and analyze the information. That's what I'm saying. It's like you're expecting AI to take not just replace the brain of a doctor, but also to replace the soul and heart and hands and feet of a doctor.
Pretty much.
I think that's asking too much, or maybe not understanding what AI is. It's just in a computer, and it's just going to give you out, but it's not going to. An AI can tell you what's wrong with your car, but it can't go change your battery. So that's expecting too much, I think, from AI in that regard.
I just think that for quirky communities like Del Norte, it's just not. It's not going to be programmed to fit them very well. I think it's the same thing that we have to deal with, on a daily basis. If somebody in LA makes a decision, applies it to Del Norte, and has no idea what reality is.
Yeah, you look at what the laws that are going to be passed in Sacramento, and you go, what?
Yeah.
What? Huh? Seriously?
So.
Yeah, exactly. Yeah. The things that make, and again, you're right. The things that make sense for a certain class or strata, social strata of person, that undiscovered self that C.G. Jung wrote about in the 50s with that book by that title, which is basically, here we're making all these decisions on a statistical average that doesn't actually exist in physical reality.
Right.
And that's what happens.
Down with the X bar.
Yeah. So I know. I can see how AI could help, and I can see how people could kind of be sucked into the fabulous beauty of AI helping, especially in a community like this, where you're just getting in front of a doctor, whether it's a human doctor or a robot doctor, is difficult.
Yeah, I want to know what the consequences are for blowing the AI off. So let's say. Let's say, I'm presented with an AI diagnosis, and I'm like, yeah, right. And I go in a different direction. Let's say it becomes like a legal matter or a quality assurance, quote, air quotes, quality assurance matter, something like that. How do I argue it?
Yeah.
So
I think what'll happen is that next time the subsequent treatments that you might require because you did not act on a previous thing, your price points will be higher. You'll have to pay more.
Interesting. Yeah. I'm sure there's money wrapped up in this, and we haven't even discussed that. There's layers of money wrapped up.
I think it's probably the sticky, gooey center is the money. Yeah.
Right. Completely. So, and will we ever be able to get to single payer? This seems a step away.
It does. Yeah. We're moving toward like the a la carte menu instead of like actually just going, just a subscription and here you go. Yeah.
Right. Exactly. So I wanted to talk a little. Are we kind of done with that?
Sure.
I wanted to talk a little bit about future topics, because Suboxone is hot in the news too, and we're hoping to get a couple of people together to talk about different directions for Suboxone and what people really need and what people might be given, and how this process is now kind of in flux right now. And it would be good for the community to know about it so that patients could use their voice now. It would be super helpful.
Okay.
And I'm not implying bad things are happening. I'm just implying it's changing.
Yeah. Yeah.
So,
and as with everything, and kind of a thread that runs through every Health Matters, it's the informed patient who gets the best care.
Absolutely.
Yeah. All right, Lynn. Well, thank you very much.
Thanks.
I didn't talk over you too much on this, did I? I felt like I got kind of fired up about AI.
No, I thought it was really interesting.
Okay, good, cool. Because I don't want to...
Are we on the air still?
No, yeah, we're still recording.
Okay. Well, I told you when I sat down that I wasn't like super schooled in this topic.
I get
that it all came together today. I've been pondering it all week. So yeah, you always give me things to think about. Like nostalgic. Am I nostalgic? Oh my God.
Of course you are.
Because it makes me old.
Well, no, but everybody, you can know. Yeah, sure.
Well,
When you're old, you've got experience and you've got things to look back on. That's what you get nostalgic over. And you get nostalgic over being able to sit around and shoot the S with all the other healthcare.
But I want it to be a useful tool.
It is for you. It's just in going forward. I don't know. Maybe the AIs will all sit around somewhere in a virtual space and talk about us.
Yeah, maybe they do. Maybe there's a virtual table. Oh my God. How exciting.
All right, Lynn Szabo, thank you very much. We'll talk next week again for the next Health Matters.
Okay.